I think Viviane's going to be sharing it.
Yeah,
And yeah, we added another slide since what we sent to you. So
that's okay. They're just for backup anyway. So that's perfect. As long as Viviane, you have the ability to share, that's great. Yes. And Jordy is our tech support. So if anything gets funky, she's our support. And yeah, okay, I think it's all right with you because I know we just have that certain amount of time. I'll go over my little quick housekeeping blurb. So welcome everybody to room A. I live, learn, and love in the Seal Okanagan Nation, and you can continue to share acknowledgements in the chat box if you're just joining the session now, if you didn't join for the coffee tea this morning. Remember that your cameras and speakers, you're able to be heard and seen at all times, and we encourage that. So please feel free to share your camera. We'd love to see faces, and note that you're able to speak by unmuting yourself. We're recording the session today. There are 6 presentations, 30 minutes in duration, set back to back, and speakers will be notified through the chat when they have 5 minutes left. And I will get right into introducing today's speakers. So this presentation will be from 9:30 to 10 a.m. and has Charlotte Jones, Associate Professor with UBC, Elder Arlene Vrtar-Huot, an Elder Advisor with the Métis Community Services BC, Mary Cutt, a Community Research Liaison with the Cariboo Friendship Center, and Viviane Josewski, Doctor with the Department of Medicine of UBC Okanagan. The presentation title today is Using Indigenous Methodologies to Co-Develop Urban and Rural Community-Led Diabetes and Obesity Telehealth in BC. And take it away to your group.
Thank you. Just a moment. So, yeah, thank you so much for the introductions, Kim, as well as to the organizers at Interior Health and the Rural Health Services Research Network BC. We're very excited to be here today and share our preliminary results. To start us off in a good way, we have Métis Elder Arlene Vrtar-Huot and also our Elder Advisor on the project open our session with an acknowledgement and opening prayer. Arlene. Arlene, sorry, we can't hear you right now.
First mistake of the day. Baumata, good morning. My father was a Métis speaker, but sadly I'm not, and therefore I apologize if I mispronounce my ancestral tongue. I'm so pleased to open up this presentation today with a prayer and also to acknowledge the urban Indigenous friendship and Métis communities located in Williams Lake, Lillooet, Kamloops, and Kelowna, all which have made the foregoing work possible. Without them, just couldn't have been done. Okay, so respectfully, if you're able to, you can join me for the prayer. Creator, Father God, Holy Spirit, Jesus, we ask you to come gently and lovingly into this assembly today. We ask you for your continued guidance and support and direction for this important work on this day and for all of the days to come. Bless everyone here and their families. We are forever grateful for this opportunity to respectfully live and work within these ancestral and traditional territories. Marcy, all my relations. So I thought before I ended and turned it over that I would just give a little bit of information about my Métis history, and when a person does that, of course, it just helps people to know a little bit more about Métis. So my ancestral name is Arlene Rosemary Gervais, and this comes from my long history of Métis family ties. My 4 times removed great-grandfather, Jean-Baptiste Gervais, was born in 1790. He was married to Madeleine Bonneau, who was the daughter of whom was only recorded as Louise Indian, born in 1760s. My great-grandfather, Alexis Gervais, 3 times removed, was born in 1822 and within the traditional territory of the Métis Red River settlement. Alexis was in possession of Métis land scrip, issued in the 1870. My great-grandfather was Patrick Gervais, who was also involved in the Battle of Batoche. I have pictures of him proudly wearing his Métis sash and his moccasins. That's a precious picture to me. During that siege, my grandmother was standing in the kitchen tent with her baby son, Herman, in her arms. A bullet not only passed through the tent, but also through the crown of her hat. This was a pretty close call for a young mother. My grandfather, John Gervais, was born in 1880. He was married to my great-grandmother, Flora Ducharme. John operated a lumber shipping raft that drifted down the river from Edmonton to the Battle River, and he supplied most of the lumber that was used to build the town of Battleford. John had my father, Adelard, also known as Edward, or Eddie Gervais, and 6 other children. Edward, my dad, was a World War II veteran, and he had many tours of duty in Europe. Upon his return, he was employed by the Department of Indian and Northern Affairs to work as an Indian agent. He worked at that for 25, 30 years. He married my Métis mother, Lisa Henry, who descended from a long Métis ancestral line of Elmira Garapi and Narcissus Henry. They had 7 children, one of which was me, Arlene, Rosemary Gervais. We lived in Alacrosse, Saskatchewan for many years, and the Michif that I grew up with was the Northern Area Michif. I attended Beauval Residential School in the same area. I have fond memories of canoeing and shooting the rapids with my dad at Buffalo Narrows and Canoe Narrows until age 16. I lived in Saskatchewan and then moved to Alberta, where I officially registered as a Métis. I moved to BC, and in order to be counted as a Métis in BC, I was required to register again for the official Métis Nation status card. It's complicated, and a lot of people sometimes have difficulty in understanding how we progress to our status of Métis. So this little bit of my personal history just helps one to understand just a little bit more of the history of Métis people and a little bit more of the history about myself. And I thank you for listening. So merci. And I now have the privilege of introducing again Viviane Josewski.
Thank you so much, Elder, and thank you so much for the wonderful opening prayer and sharing with us where you're from and really reminding us of the important part that Métis people have played and continue to play in Canada and in BC. My name is Viviane Josewski. I am a settler researcher from Germany who has been working with Indigenous communities here in BC for the last decade and a half. In my current position as postdoctoral research fellow with the Faculty of Medicine at UBC, I work together with the 5 BC Interior Friendship and Métis centers who are part of this project, Interior Health, and a team of university researchers, including Métis Elder Advisor Arlene, my co-presenter, Dr. Charlotte Jones, and many co-authors who are listed here on the slide but cannot be here with us today, although I actually have seen Donna Kurtz, who's a co-leader on this project in the audience. So hello. And yeah, I'm really excited to be here today, and I give the word to Charlotte. Thank you.
Thank you, Viviane. And importantly, thank you very much, Elder Arlene. That was a beautiful opening. And I wish to say mio kisipeal to all. Welcome to all. I'm Charlotte Jones, and I am a third-generation settler with origins in Scotland and Ireland. I'm a wife, mother, grandmother. And professionally, I started out as a biochemist, but quickly realized that I would prefer to embrace people rather than test tubes. So I became an endocrinologist and have 20 years experience in initiating new telehealth projects and also in community-based participatory research. I'm honored to be working with so many wonderful partners and communities in this and all our projects. So I'll begin our story with some background on the study, and then Viviane will provide some detail on the Indigenous methodologies we use and some of our preliminary results. Can we have the next slide? Yes. So many of you know that Indigenous peoples globally bear a disproportionate burden of poor health and wellness due to historic and contemporary colonialism, systemic racism, and an ongoing lack of culturally safe care. Specifically, making up as many as almost 80% of Indigenous peoples in BC, urban, rural living Indigenous people face jurisdictional funding and policy barriers that have left many with unmet health needs, including less access to traditional healing practices compared to community members living on reserve. Given these barriers, many are reluctant to access mainstream or Western health services and subsequently experience increased rates of diabetes, obesity, and their complications. It's becoming readily apparent that Indigenous-led health services and partnerships with foundations in local Indigenous ways of knowing and being and Western knowledges together improve culturally safe care and holistic health for Indigenous peoples. In response to these inequities and evolving from many years of relationship building and listening, some funding was obtained. In 2015, 3 interior BC friendship centers located in Williams Lake, Kelowna, and Vernon expressed their need and identified the urgent need for locally informed, culturally safe, and relevant diabetes and obesity programs and services. Some of the vision included greater access to care, community belonging and learning together, cultural safety was paramount, health education, traditional healing, and food security and nutrition and education. Then in 2018, kamloops, next slide, please. Then in 2018, Kamloops Aboriginal Friendship Society, Lillooet Friendship Center Society, and the Métis Community Services joined the group and voiced these same needs and priorities. It was during talking circles and at a community gathering held in Kamloops in July of 2019, basically the last time we were in person together. It was there that the plan and initial co-design of the I'm to Care, or the Indigenous methodologies for telehealth care, was hatched. The idea began at that point. Funding then in 2019 was obtained from AgeWell National Centers of Excellence to realize the community's wishes and to work together to create a culturally safe diabetes and weight management project and clinics.
So the three overarching objectives of I'm to Care are to collaboratively develop, implement, and evaluate an accredited Indigenous diabetes and weight management training workshop for physicians and local providers. Number two, to co-develop, implement, and evaluate an Indigenous-led, culturally safe, and multidisciplinary telediabetes and weight management service for urban Indigenous adults. And thirdly, to co-create and disseminate a telediabetes and weight management implementation toolkit for communities, other communities who might be interested in creating their own telediabetes and obesity clinics. So to realize these objectives, it's really important for the team to continue to do this research in a good way. Two-eyed seeing is the guiding principle by Mi'kmaq elder Albert Marshall. And two-eyed seeing brings together and acknowledges the strength of both Indigenous and Western knowledges, and is thus particularly applicable to this research, which really seeks to bring together Indigenous and Western understandings and responses to diabetes and obesity. And in keeping with the principles of two-eyed seeing, our research partnerships have been guided by the principles of respect, relevance, reciprocity, and responsibility, which is also known as the 4Rs approach. So this means, for example, that we have established community research agreements in place with each participating community, and that articulate the values that guide our research partnerships, as well as our mutual responsibilities. And to walk together, I'm to Care draws on Indigenous methodologies, community-based participatory action research, and Indigenous approaches to integrated knowledge translation. In other words, I'm to Care not only honors and is shaped by local Indigenous knowledges, spiritual beliefs, values, and customs. It is Indigenous community-led research with, by, and for Indigenous peoples that seeks to decolonize how knowledge is produced, and also the way we approach diabetes and obesity care. So this means, in addition to more Western research methods, such as surveys, I'm to Care also uses culturally grounded methods, such as elder-facilitated talking circles and annual gatherings. Regardless of the method, nothing in I'm to Care is done without the community's input. This means we are working very closely alongside elders, traditional healers, knowledge keepers, community members, Indigenous physicians and nurse practitioners, community research liaisons, and Friendship and Métis Center executive directors and staff, of course. And rather than me or some other researcher going into the community, it's the community research liaisons that are the ones who are recruiting and consenting participants, and they may also accompany participants to the clinics themselves, and also fill out after the clinic surveys with participants. The community advisory teams, the CADs, are another example of how we work together with communities under community direction. Each CAD includes a knowledge keeper, elder, traditional healer, community member who has participated in the telehealth clinics, as well as an interior health diabetes educator. And together, the CADs really provide direction to anything we do together in terms of developing, implementing, and evaluating the clinics. And in addition to communities who are the driving force behind this research, we are also working very closely with Interior Health as a key partner. So clinics are currently provided with the help of 2 Interior Health diabetes education centers, one in Kelowna and another one in Kamloops, with the support of 4 committed and really fantastic Interior Health diabetes educators, 2 at each site. In addition, I'm to Care is championed by people working within Interior Health at both the managerial and director level. And on the right here, you can see a picture that depicts all the different parties involved in I'm to Care decision-making, what we sometimes refer to as the circle of care.
In response to the community's wishes for increased access and culturally safe care, and if possible, Indigenous care providers, we got together with 6 rural and remote Indigenous physicians with experience in telehealth and got input into their needs assessment for training to obtain extra expertise in diabetes and weight management. We also included input from nurses, nurse practitioners, and dietitians, and together came up with an 8-hour, 4-module training workshop that has been accredited by UBC. And the workshop is basically starting with a really excellent video on cultural safety, and works through management of type 2, type 1 diabetes, gestational diabetes, and ultimately a weight management module. And these are all based on the most recent Canadian guidelines, in addition to the input from the other individuals involved. So our first training workshop was held in November and December of 2020, and presented by a couple of endocrinologists, some nurses, including Donna Kurtz and Viviane, and myself, and also a dietitian. At that time, there were 6 participants, 2 Indigenous family physicians, 2 nurse practitioners, and 2 dietitians. And their overall impression was that it was either above average or excellent. And I think you'll see has provided increased access to some of the individuals who might otherwise not have accessed any telehealth program for that matter.
So, and now to some of the preliminary results. Up to date, we have 3 centers who have successfully launched the telediabetes and obesity clinics for their communities, with a total of 23 clinic appointments. Of these, 11 are first appointments, 9 are follow-ups, and 3 are booked for the future. It's important to know that the first visits are really about relationship building. So they take around 60 minutes and involve the diabetes educator, the participant, and potentially a support person that the participant chooses to bring. And as you can see on this beautiful picture here, which has been created by Métis artist Danica Bleu, community members have currently 3 different ways of participating in a telehealth diabetes and weight management clinic. And the first one here is through virtual home appointments, where the participant joins from home, and the diabetes educator and potentially the physician are joining in via Zoom. You can see we had a total of 8 virtual home appointments. The second one down here is an option where participants are coming in person to the Friendship or Métis Center to join the telehealth clinics there virtually. So this has, of course, the advantage that we can address in some ways, or to a certain degree at least, the inequities in terms of internet and technology that can create significant access barriers for many Indigenous community members. And the third option up here depicts a situation where participants are in the Friendship or Métis Center, and they are joining the clinics virtually, but the community research liaison is joining them as well. And as you can see from the overall 20 appointments that have taken place already, 13 appointments actually included the community research liaison as a support person. So very many people actually choose this option, and really helps with relationship building, navigating any technological issues that might be there, and just having an advocate on the side. So building trust and just improving access to clinics. So in terms of the results, a total of 11 community members have attended telehealth clinics, and the majority identified as First Nations, with a small number of people identifying as Inuit and Métis. And notably, 82% of people reported living off reserve. So this is really important because one of the key objectives of ImToCare is, of course, to increase access to culturally safe diabetes and obesity services for Indigenous people living off reserve in urban and rural population centers, for the reasons that Charlotte has already explained in the beginning. And you can see we have more females than male. We have 9 participants who identified as female and 2 as male, within a really wide age range from 19 up to 74 years of age. You can also see that only 7 participants actually had a family doctor from all participants participating. So there is a significant number who don't have a family doctor, and it's just really important for them to be connected to care. And finally, we have ImToCare offers 2 different clinical pathways at the moment. One pathway is for people who have a diagnosis of diabetes, and we can connect them to the telehealth services with the diabetes centers. And then we created a second pathway specifically for people who don't have a diagnosis with diabetes, but who have weight management issues. And so we have created pathways for people who have experienced weight management issues, and 2 of them have been connected so far with the clinics. So to evaluate clinic participants' experiences, we currently have community research liaisons conducting after clinic surveys with the participants. We're doing this for the first 1, 2, 3, or 4 clinic visits, just to make sure we capture participants' experience as they move along. And also later on, we are planning on conducting a number of elder-facilitated talking circles with participants, and we have some coming up, but so far we haven't actually had the chance to conduct any. So the clinic surveys include a range of open-ended and closed questions, and here are a number of quotes from participants that we're going to share with you right now.
What I liked best about the visit was having an elder as my support.
This experience has altered my health, and I encourage more people to participate. It has kept me accountable.
I was surprised. I liked it. I felt heard and supported. This telehealth program was sure good for someone like me. And to me, Charlotte, this means a lot. This individual is benefiting, and that's wonderful.
And another person said, I liked so much of it. It felt very caring and sincere in supporting my health.
I feel really comfortable.
I felt supported and appreciated the suggestions.
I'm just very thankful for the overall support and help dealing with the diabetes.
The nurses were helpful and understanding. And I think you can see from those quotes what participants said, that they really valued the clinics overall and felt safe and comfortable, which is just really so important considering what we know about the degree of racism that's currently still being experienced within mainstream services by Indigenous peoples. So feedback from the quantitative questions are painting a very similar picture. Overall, participants rated the clinics very high. Even after the very first clinic visit, 100% of the participants agreed very much with the statements that they were listened to and that their questions were answered. And also everyone agreed with the statements that they felt safe and comfortable asking questions, and generally during the visit. Although not everybody agreed very much with those statements at this point. The one question that got more mixed results than the rest was the first one, whether or not participants felt that now know what to do next with their self-management of their health. And of course, this is not completely surprising to us, given that one visit may not be enough to get people to a point where they do know what to do. And we were hoping very much to see improvements in relation to the last 3 statements over the course of people's journey throughout the project. And here's what we did see. After the follow-up appointments, all statements improved in terms of their readability. Like, so we have everybody agreeing 100% to the most important questions here. And we have also a significant improvement in relation to the first one, where people said that they now do know what to do next with their self-management of their health. And so I just want to also take a moment to speak or address some of the challenges that communities are facing throughout the project. And of course, one of the largest or most, I guess, impactful barriers or challenges that communities are experiencing right now here in BC specifically, and the communities that we are working with, is the unmarked graves of children that attended residential schools in Kamloops and Williams Lake. So that had had a tremendous and continues to have tremendous effect on communities. Of course, COVID-19 has had tremendous impact as well. Just has been really a change for communities to switch over everything into virtual. As I had mentioned before, there are a lot of inequities that Indigenous community members experience. So coming together virtually was something new, although I think communities have done a wonderful job in doing this and adjusting. So that's really amazing. And then, of course, as everybody here probably is really aware of, we had all those natural disasters in BC, including the wildfires, including the floods, and many of the communities were directly impacted by it. For example, the Friendship Center in Liaison, I know, for example, took in many of the people from Merritt when the town was flooded. Also had close ties to people being impacted by the wildfire. So it's those kind of reasons that come up and create a barrier for communities to participate. And of course, as we're working with the communities, we have to acknowledge and reiterate and emphasize that research doesn't come first, it's communities that are coming first. And the final challenge is that many of the communities that are located more in rural areas, such as, for example, the Cariboo Friendship Center, which is in Williams Lake, experience significant barriers around having access available or availability in terms of healthcare providers. So currently, I think there's an extreme shortage of family doctors in Williams Lake. And even though, for example, there is an Interior Health Diabetes Education Center, they don't have the capacity to participate in this project, which is why Williams Lake and the Cariboo Friendship Center is actually connecting with diabetes centers in Kelowna and Kamloops at the moment throughout the project. And of course, we're hoping that in terms of sustainability, this is something that can be addressed as we move forward.
Viviane,
yeah.
And group, I'm so sorry, but we're actually over our time. Is there a way perhaps that we could ask attendees to be able to contact you for further information? Is that a possibility at all?
Absolutely.
Again,
yeah, sorry, I didn't see a message here, but yeah, this was our last slide. Anyhow, please contact us. We would be happy to answer any questions, and yeah, we're looking forward to any questions you might have.
Thank you.
Thank you so much.
Thank you to all you presenters so much, Charlotte, Viviane, and Arlene. This was enlightening and also inspiring, and just a wonderful initiative to see moving forward. And we really look forward to hearing more in the near future. And for folks, everyone's information is also available on FeedLoop. But if you have any issue getting a hold of any of the presenters today, feel free to message me or research@interiorhealth.ca, and I'd be happy to facilitate connections moving forward. Thank you all so much.